We move on to another session, and this is anemia in CKD. This is Dr. Lalit Pursnani, who is already there. I can see him. And for this, we have Professor Alok Gupta as a chairperson. I request Dr. Alok Gupta to please introduce Dr. Lalit Pursnani and go ahead with the session.
Just one thing. Hello,
yes.
Am I audible?
So, good afternoon. I think this post-lunch session is, there could be many interesting topics, but there is letharginess also. And we have seen that in last lecture, that hyponatremia is one of the cause of letharginess, fatigue, and so many things. Similarly, in CKD patients, we see that when we were sitting in the OPDs, busy OPDs, I was always telling our undergraduate and postgraduate students that any person who comes with anemia, hypertension, or any such complaint, please go for the investigations ruling out the kidney disease. So we have with us Dr. Lalit Pursnani, who is associate professor of the Department of Nephrology and is working in. He has got more than 10 years of experience. He is working in RML Hospital, actively involved in teaching and undergraduate and postgraduate and DM nephrology students. He has got numerous publications in various national and international journals. So I hand over the proceedings to Dr. Lalit Pursnani, please.
Thank you, sir, for the kind introduction. And I'd like to, without wasting further time, I would like to start with the presentation. As we all know, my outline of the outline would be including prolyl hydroxylase inhibitors, the new pivotal trial for IV iron, the dialysate iron, and the new oral irons. As we all know, the anemia is the most common and the significant comorbidity in all CKD patients. So why do we need to treat it? We'll start with an index case. Okay, we'll start with a case. There is a 62-year-old woman with 10-year history of CKD from diabetes, which has a slowly progressive renal function, worsening renal function, past medical history of a right CVA stroke, and she sees you in the office. She feels great. She's working, exercising, eating well, and the lab data shows BUN of 48, creatinine of 4.2, eGFR of 80, hemoglobin of 8.9, and TSAT of 30% and ferritin 282. So what would you do? Either would you like to start this patient on an ESA or darbepoetin, or would you empirically treat her with a course of intravenous iron, or check stool guac, and if all right, continue to observe her. In the next further slides, we'll see what is the fresh evidence to treat these patients. Sir, are the slides moving?
Click on the slide. Just click on the slide and it will move.
Yes, sir.
Click on the slide. Yeah, click on the slide.
Okay.
It will.
Okay.
Yeah.
Okay, sir. Okay. So the next slide. Why would we not treat her with an ESA or anything else? As you can see in our case, she's asymptomatic and as well has a history of stroke. So what only thing we would do, we would work up for iron deficiency anemia and see if she's not bleeding. And remember that there is no evidence that mild anemia treatment is a disease modifying treatment. We only treat anemia when there are symptoms in CKD patients. This is a timeline of drug development of EPO analogs, and almost the first EPO studies were reported in 1986, and there have been multiple studies over the year, And the final study came out in 2009, which was the COIR and the CREATE studies. So we'll be seeing what is the evidence for the management of anemia in these CKD patients. What the US FDA label says is, for patients with CKD not on dialysis, consider initiating ESA treatment only when the hemoglobin is less than 10. And what the KDOGI anemia guidelines, which were published almost 10 years back, say the same thing. They say, in initiating and maintaining ESA therapy, we recommend balancing the potential benefits of reducing blood transfusions and anemia-related symptoms against the risk of harm in individual patients. So the treatment should be individualized. And they say we recommend using ESA therapy with great caution, if at all, in CKD patients with active malignancy, in particularly when cure is the anticipated outcome, or there is a history of stroke or a history of malignancy. So these were some of the major trials for management of anemia in CKD. The first trial was normal hematocrit cardiac trial. The other one was the Canadian cardiac trial. The third one was the CREATE trial, cardiovascular risk reduction by early treatment with iptoin beta, or the COIR trial, correction of hemoglobin and outcomes in renal insufficiency. And the last one was the TREAT trial to reduce cardiovascular events with arnesterone, which is darbepoetin. As you can see in this slide, a bit congested slide, what you can see in the greenish portion, you can visualize that none of these studies which aim for higher hemoglobin levels, in the normal hematocrit study, there were two groups. Either one was 10 grams, the target was 10 grams, and other had a target of 14.5 grams. And as you can see in this study, normal hematocrit study, patients who achieved higher hematocrit had more mortality, and there was no improvement in health-related quality of life. Even in the COIR study, you can see that the targets were either 11.3 or 13.5, and patients who had a higher hematocrit level of 13.5 had more mortality, and there was no improvement in health-related quality of life. Even in the last study, the TREAT study, you can see that the patients who were between the two groups, between the 13, and they could see that the patients who had higher hematocrit did not benefit from the other patients with the lower hemoglobin levels, and there were equivalent death, MI or myocardial ischemic or heart failure, stroke risk, and as well as there was no benefit in renal progression, and there was no improvement in health related outcomes. So there is some signal from these studies that you do not achieve much by targeting a higher hematocrit. So what does the KDIGO and the FDA says? Treatment target should be around, for KDIGO, should be around 11.5 to initiate ESAs in dialysis patients, and for FDA less than 11 in dialysis patients. Now, what about the lower number when you need to initiate? In non-dialysis patients, the KDIGO says once it goes below 9, then only you should initiate ESAs. And FDA says if it goes below 10, then only you should initiate ESAs. But why there is this number 9? In dialysis patients, there was evidence from the normal hematocrit study, as well as in the non-dialysis patients, there was evidence from TREAT study that patients did not benefit much from these, from higher hematocrit levels if they were initiated early, even if the patients were asymptomatic, and it resulted in more cardiovascular events. And as such, there is, for dialysis patients, there is a target between 11 to 12 from all the studies. So what is the management algorithm? You should, once the hemoglobin goes below 11, one should be ruling out iron deficiency, erythropoietin deficiency, or some underlying inflammation. And if the stool for occult blood is positive, then most likely it could be iron related deficiency, and you should look for ferritin and T saturation, and should be given a treatment with oral iron therapy for at least 3 months. If there is an ESA deficient stage with normal iron stores, normal folate, B12, no evidence of inflammation, and no evidence of occult blood loss, then you can initiate ESAs. And if there is an inflammation, which you can see from the investigations like hypoalbuminemia, increased ferritin levels, or increased HSCRP, then you should decide how should we initiate ESAs, and trigger ESA initiator if the patient is symptomatic or is a transplant candidate and you do not want to give him transfusions. Most target for non-dialysis patients should be between 9 to 10 for most patients, and a target of less than 9 if there is a history of prior stroke or active malignancy. So the current recommendations are use ESA therapy if HB is less than 10 and if less than 11 if symptoms. Aim for target of 10 to 12 grams, though you need to individualize. Do not exceed intentionally 13 grams. Use lowest doses of ESA as possible. Use supplemental iron to prevent iron deficiency and reduce EPO doses. And aim for a ferritin more than 100 and TSAT more than 20%. And there is some studies which say that the ferritin level should not be exceeded more than 100. So, but the upper limit is still not defined. So coming to our index case, 2 years following initial presentation, she felt fatigued with minor tasks, has difficulty getting out of bed. HB has remained static around 8.9. Iron stores are replete. She started on ESA and her HB responds and she feels better. 6 months later, she develops an ulcer on her foot and her HB starts to drift down. Despite a gradual 3-fold increase in darbepoetin alpha dose, now at 120 micrograms per week. So the question is, what should be done next? The patient should be treated with a course of IV iron. The patient requires a blood transfusion in order to get her HB into 11 to 12 range recommended by NKF. The most likely cause of her ESA resistance is diabetic foot ulcer. You should not escalate her ESA dose. Instead, focus on treating her foot ulcer, and she should be treated with an anabolic steroids. So the answer would be, most likely cause for her ESA resistance is diabetic foot ulcer, and you should not escalate her ESA dose. Instead, focus on the treating her foot ulcer. And we'll see how to manage this ESA hyporesponsive, which is quite common in CKD patients because they have an underlying inflammatory state. So what does the FDA and the guidelines define as ESA hyporesponsiveness? ESA resistance or hyporesponsiveness patients who do not achieve the desired hemoglobin concentration despite higher than usual doses of ESAs, or who require increasingly higher ESA doses to maintain an HB concentration. There is a KDOPPS definition which says a failure to achieve or maintain target hemoglobin levels at an erythropoietin dose of 450 international units per kg per week when administered intravenously, or 300 international units per kg per week when administered subcutaneously. So what are the causes of hypo? The most common causes of ESA hyporesponsiveness are either iron deficiency and inflammation, which could be both infectious or non-infectious, like a failed kidney allograft or something else. Or there may be other reasons like inadequate dialysis, hyperparathyroidism, carnitine deficiency, drugs like ACRBs, aluminium overload, nutritional like folate, B12, vitamin C deficiencies, malignancies, or hematological disorders. So what happens actually in CKD? There is a reduced GFR, and with iron supplementation, inflammation, and vitamin D deficiency, there is an increase in the levels of hepcidin, which is a new molecule which has been recently discovered and has a major role in iron metabolism in CKD patients. And it does two things. Once the hepcidin levels rise, it inhibits the iron release from cells of reticuloendothelial system, as well as inhibits gut iron absorption. So there is an iron restricted erythropoiesis, which results in ESA hyporesponsiveness. Why do these patients have? There is a unique problem with CKD patients. Most of the CKD patients we see have either high ferritin levels and low TSAT levels. What happens is actually as the GFR declines, the hepcidin levels start increasing, and the micro-inflammatory state in the CKD patients also leads to increased hepcidin, and this causes less poropoietin on the cells, which actually helps in gut absorption as well as uptake into the reticuloendothelial cells or release from them. So that iron is trapped in the reticuloendothelial cells, which results in and also results in lower GI iron absorption, and hence lower serum iron and TSAT. So what can we do for such patients? We should first diagnose it, avoid repeated escalations in ESA dose, identify the correctable versus non-correctable causes. If there is, we should look for iron deficiency, we should look for all the other vitamin deficiencies, we should look for hypothyroidism, and we should look for if we can change the patient from ACE or ARBs to other drugs and look for non-adherence. And we could give them treatment for iron deficiency or vitamin deficiencies if there is absolute iron or B12 deficiencies. Once otherwise, if there is a functional iron deficiency, as we discussed in these patients which have high ferritin levels and low TSAT levels because of the increased hepcidin levels, we can give them a trial of IV iron. And if there is underdialyzed, we should normalize his dialysis prescription. Look for any bleeding from anywhere, correct hyperparathyroidism, look for malignancy, malnutrition, or pure cell aplasia. And if it's impossible to correct, hemoglobinopathies or bone marrow disorders we should look for. So coming to the new kids on the block are the HIF stabilizers or the prolyl hydroxylase inhibitors. In 1991, HIF1 was discovered, a protein with DNA binding activity to the erythropoietin gene. There are two isoforms or subunits of HIF alpha, 1 alpha, which regulate target gene in response to hypoxia. And HIF1 alpha is mainly under the control of oxygen sensing prolyl 4 hydroxylase enzymes. And recently in 2019, Nobel Prize in Physiology of Medicine was awarded to these people for their discovery of how cells can adapt to the oxygen availability. There is some data which says that it is an interesting story how they came upon this chance discovery. And they could see there was a tribe in Chuvashia, Russia, who have polycythemia, and it is endemic in this population. And they had some mutation in this von Hippel-Lindau gene, and they had polycythemia, though there was no increased incidence of tumor incidence, or there was reduced life expectancy due to polycythemia, and there was pulmonary hypertension. So they looked into these patients and they could see some mild mutations in such patients, especially in PHD2 and HIV2, and they could see, and they thought that this could be utilized as a therapy for anemia. So there was a study which showed that single dose study of prolyl hydroxylase inhibitors in humans, in the healthy controls, there was mild elevation in the EPO levels, whereas patients with anephric HD patients had mild elevation in EPO from the extrarenal side, that was the liver. But patients with patients on hemodialysis had major elevations in EPO levels. There was EPO production both from the extrarenal, that is hepatic side, as well as from the renal. So there was some preservation of the EPO production activity in these patients. There are 3 leading PHIs in the market which are going to be launched in the market most likely next 2 years. They are under trials. They have almost completed their phase 2 trials, and they are going phase 3 trials are going on. They have almost similar mechanism of actions, though different physical properties, and all of them are oral agents: daprodustat, vadadustat, and roxadustat. And you can see in this slide the doses are mentioned and the half-lives are mentioned, so I'm not going to go into the details of these. There have been some phase 2 trials, and though they are not different from the ESAs, there have been some concerns about the cancer-related mortality and tumor progression and recurrence. There are some cases of pulmonary artery hypertension and cardiomyopathy. There is some concern regarding proliferative retinopathy, macular edema, or choroidal neovascularization. And there's some reports of exacerbation of rheumatoid arthritis. There is a phase 3 trials are going on in China, in Japan, everywhere. And we'll be having this data by next year. So to conclude, first conclusion, there are currently guidelines on anemia treatment say the target should be between 10 to 11 for non-dialysis patients, and for dialysis patients around 11 to 12. And ESA hyporesponsiveness is an important factor in anemia management. It could be multifactorial, it could be related to elevated hepcidin levels and inflammation. And discovery of oxygen sensing mechanism has led to the development of PHIs. There are currently 3 PHIs. It has been shown from the studies that PHIs are non-inferior to EPO for hemoglobin maintenance, and they have a safety profile similar to EPOs. They are more convenient because of the oral dosing, but are they really better than ESAs? It needs to be looked. It will be further in the studies. Now coming to the iron, which was a major significant trial in last 3 to 5 years, and this was one trial which was published in NEGM, which was a pivotal trial which says proactive iron therapy in HD. There were two groups of patients. One group received proactive iron therapy, and the target for iron was to keep TSAT around 40% and ferritin around 700 micrograms per liter. And the other group had the TSAT was kept around 20% and ferritin levels were kept around 200 micrograms, and they were given iron sucrose only as and when required, whereas the proactive group received 400 milligrams of iron as such once during the month period. And you could see they had reduced transfusions, reduced the ESA requirement, and from as compared to the reactive group. And from what we could see, most of our people are concerned about the risk of infection with the IV iron and the high iron doses. And there was no difference between the two groups. So it was concluded as such within a median follow-up of 2.1 years in HD patients that the high dose IV iron regime administered proactively was superior to the low dose regime administered reactively and resulted in lower doses of ESA being administered, and there was no difference in the incidence of infections between the two groups. So we can say somewhere that even the high dose IV iron is safe. It can be given safely to the dialysis patients. This is data from DOPPS which say high IV iron doses and mortality, and you could see that once the doses crossed 300 milligram per month, there was an increase in all-cause mortality. And for monthly iron normalized to body weight, there was an increased risk of CV-related mortality if the doses was more than 6 milligram per kg per month. And the hospitalization rates were also elevated if the IV iron dose was more than 300 milligrams. So try to avoid more than 300 milligram per month of IV iron. There is a new kit also on the block. This is specifically for the dialysis patients. It is called Ferric Pyrophosphate Citrate, and this is an iron citrate pyrophosphate complex, which is a soluble non-colloidal iron salt, non-conjugated with the sugar moiety, and it is added to the bicarbonate concentrate in the dialysis patient, and it crosses the dialyzer membrane during HD and donates iron directly to the transferrin, largely bypassing the reticuloendothelial system. So it replaces the ongoing blood losses or iron losses during the dialysis treatment, and dialysate iron concentration of 2 micromoles maintains iron balance without overloading iron stores. And it is indicated for iron replacement and HB maintenance in adult CKD patients on HD. And it has received FDA approval in 2015. This study was done, prime study by the Ajay Gupta group in US. And they showed that there was significant increase in the serum iron and significant decrease in the total iron binding capacity, and there was significant increase in the TSAT saturation in patients, and there was almost 35% reduction in the ESA dose with the use of ferric pyrophosphate citrate during dialysis. This was another study done by Fishwain group, and they showed that the regular administration of ferric pyrophosphate citrate during HD by addition to the dialysate was well tolerated and effectively replaces ongoing dialytic and uremic iron losses, thereby maintaining iron balance in HB concentration. These are some of the newer oral agents available with us right now, oral iron agents available. As you can see from this group, most of the irons we used to have initially in the market were ferrous salts, but the two new there are other salts which has come up in the market. Two of them are the ferric salts. One of them is available in India, and the other one is still not available in India and has not undergone studies in dialysis patients. It has only been approved for inflammatory bowel disease patients. This is ferric maltol, and people are regularly using this new other salts which are liposomal iron and heme iron polypeptide, but there is not strong enough data to support its use over other iron or older iron preparations. So there is no, it only adds to the cost. There is no significant, but there's only one benefit with these salts. Either these salts have different mechanisms of uptake, so they could be used in patients who have underlying inflammation, and secondly, they have good tolerability. Usually the older iron agents were not well tolerated by the people. They had many gastrointestinal complaints with these, but otherwise, as such comparison, head-to-head comparison, the newer oral irons have not been shown superior to the older iron salts. And to mention in the last slide, I would mention that there is a ferric citrate salt which is available. Specifically, it has been introduced for the dialysis patients. It was introduced as a phosphate binder, and it has shown to improve serum ferritin, serum iron, and TSAT levels. So it has shown to reduce ESA and IV iron requirements in dialysis patients. So the conclusion, the pivotal study is the first large-scale randomized clinical trial of high versus low-dose IV iron in dialysis patients, and it has demonstrated better outcomes with high-dose IV iron. Dialysate iron replaces ongoing iron losses in HD patients, and there has been decrease in IV iron and ESA requirements with its use, but its uptake has been slow due to concerns regarding iron staining of the dialysate lines and some risk of infection because of the addition to the bicarbonate part of the dialysate. And there are new oral iron agents have significant impact on the iron parameters with better tolerability. Thank you, sir. I'm open for questions, sir. Hello.
Dr. Alok.
Dr. Lalit, it was a very nice presentation with so many insights about the newer iron compounds, as well as the role of IV low dose versus high dose iron and newer compounds in the pipeline, which I think that everybody must have been benefited by this nice presentation. So I invite any lecture, any question related to the lecture. Any question, please.
So you said liposomal iron doesn't provide any benefit as such
Yes,
as
sir.
compared to the. Now, of
Yes,
course, whatever literature has come of late during the last 3 years, there is an effect on hepcidin on.
Yes, sir.
Give any advantage? There is no advantage of using those drugs?
No, sir. It has been clearly shown from the study. It was published around 2014 or 15 in the NDT journal, and it clearly showed that it doesn't provide any additional. The problem is, sir, and if you continue giving it, it maintains iron, serum iron. But once you stop, it doesn't add to the iron stores as such. So once you stop it, the effect vanishes off. So as such, you give any iron preparation, it does the same thing. Only benefit above older iron salts, I have said it, sir, there is some better tolerability. And I also said, usually patients are, we are afraid to give these salts, oral iron salts, but I don't think inflammation is a contraindication to give oral iron. Usually infections, people are scared not to give IV iron, but there is no as such fear regarding oral iron. There is some concept that these are absorbed from a different receptor, since hepcidin blocks ferroportin. So iron is trapped inside the cells or is not absorbed in the gut. So these newer oral iron therapies have some novel mechanism of absorption. Hence, they may be beneficial, but as said, in a normal healthy subject, there is no advantage giving over other oral iron salts.
What should be the dose of IV iron, the ones which are used, iron sorbitol or other drugs which are being used, IV iron?
So since IV iron, we only use, in our practice, we use only 3 drugs. One is IV iron sucrose, the other is ferric carboxymaltose, and the third one is iron isomaltoside, sir. These are the 3 drugs. IV iron sucrose, only if you are asking, it cannot be given bolus. IV iron sucrose can only be given in a single session. You can only give 200 milligram. This is the maximum dose advised at a single time. Whereas from the ferric carboxymaltose, there is a recent study from US. Initially, FDA had given an approval of not more than 500 milligram in a week. So it had to be given 500 milligram once weekly for 3 doses. We usually give 1500 milligram if there is absolute iron deficiency. And in maintenance doses, we usually keep around 500 once every 3 to 6 months. We usually, I already told you, sir, this is the target. After the pivotal trial, we keep a target for our dialysis patients of TSAT around 40 and ferritin level around somewhere 800, somewhere maximum limit you can say up to 1200, sir. But you need to rule out infection if the ferritin levels are quite high, above 1000. Then you need to rule out infection before. Now there is a recent study from US and FDA has given an approval for it. FDA has approved that you can give ferric carboxymaltose one time bolus of 750 milligram only, and you can repeat this dose after a week.
Okay. Any other question? Thank you, Dr. Pursnani.
Thank you, sir.
It has been wonderful hearing you, and of
Thank
course
you, sir, for the opportunity, sir.
You have made the topic so simple and so understandable. Thank you very much for giving us time. Thank you very much,
Thank you,
Dr.
sir.
Alok, for sharing your experiences.